Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad you joined us this morning. Before we begin, I'd like to thank our sponsor, Altman Health Systems. Today, Brad and I are broadcasting from our administrative offices, and our very special guest is Dr. Matthew Stonestreet, an orthopedic surgeon. Good morning, doctor, and welcome to the show.
Good morning, Paul and Brad. Thanks for having me on today. I appreciate it.
Dr. Stonestreet is with OrthoUnited, a newly formed joint practice between the former Spectrum Orthopedics and Omni Orthopedics. Dr. Stonestreet is board-certified orthopedic surgeon with training in hip and knee reconstruction, focusing on complex primary and revision knee and hip replacements. We'd like to remind our listeners that our program today is also available on our podcast. You can download that from the App Store on your mobile phone. Just look for Health Matters with the Medicine Center Pharmacy, and please subscribe.
So again, good morning, Dr. Stonestreet. Tell us a little bit about yourself.
Well, I was born and raised in the Youngstown area. I went to YSU for undergrad, and then I went to NeoMed or Neo-UCOM when I was there for medical school. I did my residency training at Akron General, and then I did a year of fellowship training in Phoenix, Arizona at the Core Institute. And at that time, that's when I focused in on hip and knee replacement and kind of complex primary hip and knee replacement, as well as revision hip and knee replacement. After that, I went back to the Youngstown area. I was in practice for about 5 years there. And I've been at Omni now for 5 years, and I guess OrthoUnited for the last 9 months now. My wife and daughter, we live in Jackson, and my daughter is starting in middle school this year at Jackson Middle School. So happy to be a part of the community here, and we've been very happy.
Good. So I've attended both the former facilities for help over the years. So why was OrthoUnited created, and what the community can expect from the doctors there?
I would say that OrthoUnited was created to continue to provide excellent orthopedic care to our community in a manner that we, as the providers at OrthoUnited, think is the most efficient way to do it. Both Omni and Spectrum have been around a very long time, well before my time here. They've been around over 20 years, even 25 years. And in that time, they kind of both practiced independently of each other in a private practice model. And in that model, we think that physicians and clinicians are able to make clinical decisions and implement processes based on clinical outcomes and clinical decisions, rather than get kind of tied down in the bureaucracy of the administrative process. So one of the big reasons for us to kind of merge and join was to improve those processes and improve our efficiencies, as well as continue to provide care in the best way that we think is possible.
So, doctor, let's talk about your specialties.
Like we said, I specialize primarily in hip and knee replacement. I don't see many fracture care patients anymore. So really, at both of our practices, most of us are fellowship trained and really kind of hyper specialized. So all I do is hip and knee replacements all day, and that spans from a primary knee replacement to a complex primary knee replacement where I'm having to take out hardware from a previous fracture or a previous injury and convert that to a knee replacement, or a partial knee replacement that needs converted to a total knee replacement. On the hip side, kind of a similar scenario in which we see a lot of patients. So primary hip replacements, as well as in revision hip replacements, or hip replacements that need hardware taken out from previous fracture, previous injury, and those sort of things. I also do essentially all of my knee replacements, and probably about a third of my hip replacements with robotic assistance, and just a newer technology that allows us to improve our precision and accuracy.
It's one of the things I find interesting is in medicine, you go to if you have diabetes, you go to an endocrinologist, or if you have a heart condition, you go to a cardiologist, and so on. But it never really was brought to my attention until we had one of your colleagues many years ago on the show that was a hand surgeon, and how specialized that you and your team are in your specific body parts or areas. And I guess I didn't know if you wanted to comment on how that helps give you an advantage to knowing your role so well, given a complex body part, or am I on the right track? Or
Well, certainly, I think so. I mean, as in anything, the more repetition you get and the more exposure you get, because even though we all know the anatomy very well, everyone is different in some degree, right? So the more that we see of that diversity of the anatomy and diversity in cases and approaches, the more we're able to kind of hone in and know what is the right thing to do for people, I think. And it really enables us to say that, if you're coming to OrthoUnited, you're truly seeing a specialist that, primarily specializes in what you're having done and what you need done. So it's not somebody that's doing one or two of these a year. It's somebody that's what they do all day, every day, is focus on those parts.
Interesting.
You mentioned something earlier, and if you don't mind, for the listeners' benefit, could you describe what fellowship trained means?
So as an orthopedic surgeon, all of us go through the same amount of training. We go through 4 years of undergrad, and then 4 years of med school, and then 5 years of residency. So in 5 years of residency, you're exposed to all aspects of orthopedics. You see hip and knee, you see shoulder and elbow, you see hand. And then throughout that experience, you kind of decide, is there something that I want to further specialize in, or is there something that I would prefer to just go into practice because I enjoy all of orthopedics and continue to see all of orthopedics. So there are many different orthopedic specialties that are fellowships. So after 4 years of undergrad and 4 years of college and then 5 years of residency, or excuse me, 4 years of med school and then 5 years residency. A fellowship is an extra year where all you're doing is that specialty. So in my instance, like I said, all I did was hip and knee replacements for that year, whereas our hand specialists, all they do is hand and upper extremity for a year. Our sports specialists, all they do is, in sports, is typically kind of hip, or excuse me, knee and shoulder arthroscopy and ACLs and rotator cuffs and those kind of injuries. Or foot and ankle, where all they do is foot and ankle surgery for a year. So it really enables us to kind of hone our skills and focus on, both the breadth of disease in that body part as well as the complexity.
Okay, cool. Well, we all have aches and pains at times, and maybe we worry that it's just being a weekend warrior, or maybe it could be arthritis. Do you have any general hip and knee symptoms that we ought to be aware of that maybe could be arthritis, and warning signs for future care that we might need?
Sure. I would say that in general, pain is such a subjective thing. It's sometimes hard to fit in a box, right? But some of the, clues that would be in the textbook for knee and hip arthritis, one of the earliest is what we would call startup pain, which just means that you're sitting down for a while and you go to get up, and those first couple steps kind of take you a little bit to get going. You feel stiff, a little bit achy, a little bit sore. That's one of the earliest things that we often see. Another symptom would be, kind of the flip side of that, which is pain with prolonged activities, whether that's prolonged standing or prolonged walking. And once again, you're getting some achiness and soreness in that hip or that knee or that shoulder. Or, you're paying for it, like you said, kind of the weekend warrior scenario where you're very active one day, whether you're golfing or, just out walking around and hiking, and the next day you're pretty sore. So those are all very common kind of early complaints with both knee and hip arthritis, and really any joint pain. Typically, I would say that, if something responds to, rest and ice and maybe Tylenol or Advil or Aleve, if you're able to take that pretty quickly, then, I think it's reasonable to continue those things. But if you get into a pattern where every time you get up, you're hurting, or, your quality of life is starting to get affected by your aches and your pains, it's probably time to get an evaluation.
Interesting. I got all kinds of aches and pains. I've been standing most of my life. So whatever, I guess. Oh, God. Time for the first break, isn't it, Brad?
Yep.
You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. Friends, just a reminder to stop by the pharmacy and talk to a pharmacist about our new Health Matters Drug Savings Program. We want to help you stay well and save money.
All right, doctor, before the break, I asked you about some warning signs maybe of arthritis or the pain signals that we were being sent. And you mentioned a couple things about what people can do at home to maybe ease some of the symptoms. Do you have anything else you want to add about maybe home remedies before realizing it might be something that needs to be more than that?
I would say that, like I had said before, the most important things are kind of the easier things, right? And common sense issues. So if something hurts, rest is kind of always the first fallback, or what we would call activity modification. So, if it hurts, don't do it, right? Ice can always help after activities when something is flared up or swollen or irritated. Over-the-counter medications are kind of the next step. Tylenol, Advil, Leave, ibuprofen, all of those can help to some degree. Sometimes some compression can help, whether that be an ACE bandage or something along those lines. In terms of, lifestyle changes or preventative, arthritis in and of itself is a degenerative condition. So there's not necessarily a cure to that. So anything that we do is really trying to kind of manage the symptoms and improve someone's quality of life. But there's nothing that I can do, or frankly, anyone can do to stop or slow that down. It's just to try to stay out of the most pain that you can. So, maintaining a healthy weight is very important, because even small changes in body weight can make significant changes in the stress across your knees and your hips. So 1 pound of body weight is anywhere from 3 to 5 pounds of stress on your knees. Another way to maintain our mobility the best that we can is really exercise, right? The stronger that our muscles are around our joints, the better those joints are protected, and the better that they work and the more efficiently that they work. So in a hip setting, that's working on things like your glute muscles. So hip abduction or out exercises can help a lot there. And especially our gluteus muscles are the muscles that stabilize our pelvis when we walk. So anytime we're walking differently or limping for any reason, those areas can get flared up. So really focusing on strengthening those areas can help a lot. In a knee setting, the most important muscles for our knees are really our quadriceps. So what that means in day-to-day life is things like getting in and out of chairs or getting in and out of cars or going up and down stairs. All of those things really stress our quadricep muscle a lot. And what often happens when our knee hurts or our hip hurts is we avoid those things that make it hurt. So then the muscles get less strong and work less efficiently, and the knee hurts even more. So you get in this vicious cycle. So really taking the time out, and I think when I'm talking to people on a day-to-day basis, I really try to stress quadriceps strengthening, and they'll say, well, I'm very active, so I don't need to do those exercises because I'm active, because I walk or anything like that. And walking is great, and cardiovascular exercise is great, but really taking time to do the exercises to strengthen the muscles that allow us to do those things better is very important.
You mentioned something about stability a moment ago, and I wanted to just touch on this briefly. I had a patient in the pharmacy this last week who commented to me that he was falling several times a week, and he was dismissing that as being okay because he was getting older. And I just want to share that I think it's important that you realize that falling can be very dangerous, and it's not something that should be ignored or taken lightly. Make sure that if you're dizzy or you're unsteady, that you talk to your doctor or your pharmacist or someone, because you don't want to risk an injury because you fall on a surface that's hard or something. It really concerned me the way he framed it, that he just thought, oh, it's no big deal, I'm older, I fall a lot. That's kind of scary to me. So
No, I would agree wholeheartedly with that because, like you said, falls can turn into really difficult and bad problems at times. And there are a lot of tools that can help you improve that. And some of that is age and, our balance decreases and those kind of things. But there are many different avenues to improve those things. You could get into a physical therapy program for fall prevention. Also, occupational therapy can help a lot in terms of finding tools to help you with your activities of daily living, so you're not getting up on ladders or step ladders or trying to do anything like that to really increase the risk of a bad injury when you fall.
Interesting. So, when should a patient see the help of an OrthoUnited? I'm sorry, ortho. That's not right. United physician, and what would be the first steps of diagnosis?
So I would say anytime that you have pain that is not acute or turning into so if you have an injury and you're not able to get around on it and it's not responding to conservative management, you should seek evaluation. If you have a chronic pain that once again is not responding to conservative management and affecting your quality of life, I think you should seek evaluation. Typically, from my stand in my practice, almost and really in any orthopedic practice, almost every evaluation starts with a history, really. So, what hurts, where does it hurt, what makes it worse, what makes it better, how long has it been going on? Was it a traumatic thing, or is it just kind of been worsening over time? And then from that history, we then get into our physical exam. So, we move the patient around, see what are some exacerbating or alleviating factors. And then most of the time they'll get an x-ray. An x-ray is just a picture for us to look at the bony structure and the anatomy to see if that is contributing to their problem or if it's more of a soft tissue issue.
We see customers in the drugstores taking overwhelming amounts of over-the-counter products. And, I had a kid tell me one day he had some serious pain. He took 30 or 40 Tylenol.
Oh my gosh.
And I said, wait a minute. I said, did you look at the bottle? And did you read the directions? And, that sort of thing. But I come from a period in pharmacy where we didn't have any of these ibuprofens and all this other kind of stuff. We had nothing but aspirin. And I think Tylenol actually came out in my early career. And the one thing that I remember was Motrin was the first anti-inflammatory thing that everybody thought was the most wonderful thing in the world. And we had people lined up at various drugstores on many lists because they did not produce enough.
Wow.
I had a whole list in my store, and these people were all going to 4 and 5 other drugstores and signing up, and we only had Motrin 300 milligram. That was the first one that came out from Upjohn Company. And nowadays, I think what happens with the new product is they have to have a 6-month supply or some kind of a quota before they put it in the marketplace on whatever it is. But that was really an interesting period of time because people were about ready to shoot each other just to get that Motrin, because it was apparently, we had 800 milligram time release aspirin, which was one of the big play items. And of course, what that did to the stomach and everything else. So I do remember all that stuff, but look what we've come to. And people are knocking down all kinds of ibuprofen and Advil and all this other stuff.
Yeah, no, there's certainly a lot of different options nowadays.
And the topicals too. One of the newest topicals is really good for various types of aches and pains. So anyway, I'm a history case.
I didn't know that.
Yeah. It was really amazing when Motrin came out. We got a couple bottles, every other week or something like
Yeah.
that. So anyway, well, tell you what, aren't you time for bottom of the hour break here, Brad?
Pretty close.
Pretty close. Should we go now?
Yeah, I think we can go now.
We are 1 minute away. Okay, so we're going to take the break now. Okay. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I am your host and pharmacist, Paul White. This morning we are talking with Dr. Matthew Stonestreet from OrthoUnited. Are we all set?
We're set. So Dr.
All right.
Stonestreet, you specialize in outpatient hip and knee replacements. Tell us about the offerings for these procedures since they've really changed over the years. How about you start with the hip and tell us what would be a good candidate for this procedure?
Thanks, Brett. Yeah, things have really changed quite drastically, probably in the last 3 to 4 years in regards to outpatient joint replacement. Historically, as a joint replacement surgeon, we would be spending every day in the hospital and operate in the hospital. Patients would spend 3, 4, 5 days. A lot of patients would even go to rehab facilities post-operatively. And once again, that has almost done a 180. I would say that at this point in my practice, I probably do almost 2/3 of my joint replacements as an outpatient, meaning they go home the same day. And it really has made a big difference, I think, in specialization and efficiencies. In terms of who the candidates may or may not be, I mean, really the rate limiting step is the patient's overall health, right? So people that have significant heart or lung issues, we still tend to do at the hospital, or if they're relatively debilitated and don't have enough help at home to do that, we still do them at the hospital. But even when patients are done at the hospital, more often than not, they're spending one night and going home. And a lot of that has been in education on the front side and managing patient expectations, but also changes in approach, as well as kind of multimodal pain control, rather than just giving these patients a lot of narcotics. We try to use local injections and anti-inflammatory medicines and things like that to just allow them to really do what they're there for. They're not necessarily sick patients. They have a joint that hurts. So we really want them to get that joint fixed, get up and moving, and get back to doing the things that they want to do. And once again, COVID played a big role in that too, in that, when the hospitals were shut down and not accepting elective patients, the surgery centers and the outpatient settings really became, the primary avenue for orthopedic surgery during that time.
I remember listening 20 years ago or so to a nurse who worked in the orthopedic section of the hospital, and she apparently that time frame was way before a hip replacement or whatever went very quickly and was very sophisticated, and she would always leave the hospital today, and my God, she said the pain is just terrible. Or the noise or whatever of the people, So we get out of there in a day with a hip, and most of them. That's pretty correct, isn't it?
Oh yeah, I would say that hip replacement surgery patients do very, very well. And you do have surgical pain. And once again, we manage that in a number of different ways. But a lot of these people have debilitating pain before they come in. So they already have a high level of pain that they're dealing with on a day-to-day basis. And in a hip replacement specifically, a lot of that kind of bone on bone degenerative joint pain goes away pretty quickly. You have some muscle soreness and things like that from the surgery itself, but the pain almost when they wake up is different than when they went to sleep, because they don't have that bone on bone arthritic pain anymore. So hip replacements do very, very well. And some of that it has to do with the approach itself. I do an anterior approach, as do a lot of surgeons here in Canton and a lot of surgeons at at OrthoUnited, which just allows us to kind of go between muscle planes rather than causing significant muscle damage. So that plays a big role in their initial recovery as well.
I had a lady staff member years ago who had hip replacements, and she was allergic to one. Is there such a thing, or?
It's very, very rare. So the implants that we put in, some of them are cobalt chrome, and some patients have some metal allergies. It is incredibly rare that it is a response enough to, you know, have cause for a second surgery or a revision. It is possible. A lot of the implants that we use today, my standard hip implant is a titanium femur and acetabulum with a plastic liner and a ceramic head. So in that scenario, the amount of allergy to that titanium is very, very, very minuscule.
Okay, so I get a hip replaced and you release me within 24 hours. Is it accurate?
No, I would say if you get a hip replacement at either, you know, OS3 on the Spectrum side or Oasis, which is our Omni Surgery Center, you're there about 6 hours at the most.
Oh my gosh, I'm kidding.
You're there typically an hour or two before surgery, and then anywhere from an hour to two for the surgery itself, and then 2 to 3 hours afterwards, depending upon how you wake up from anesthesia. And we mobilize you there with our nurses. We make sure you're walking safely with a walker. We make sure you're doing stairs before you leave, and then you get to go home.
Oh my gosh, that's really amazing.
Mhm.
It used to be weeks or days or whatever they stayed in the hospital.
Yeah.
You know, after. Now, do you bring those people back within a day or so for therapy, or
So oftentimes what we do, and I can only speak to kind of our protocol, is if we will have a therapist go to their house the next day for a home therapy session, you know, to kind of do a check to make sure they're doing well, but also kind of start their exercises. And then more patients than not, I prefer that they start outpatient therapy kind of within 3 to 5 days. So in that scenario, they're coming to, you know, either one of our facilities or a therapy facility convenient to them to work to start their recovery process.
and a person who wasn't badly debilitated when they came in for
Mhm.
surgery, can they be moving around and walking in a couple of days?
I
And
mean, once again, you're walking the same day. Everybody does use a walker at first, whether that's a hip or a knee replacement, but those are just tools to protect them from falling. So as soon as they feel comfortable without the walker, they can go from a walker to a cane to really nothing. So the variability there is huge. I have patients that use a walker for a day and some, you know, and sometimes for a couple of weeks, but anywhere in between there. But it really makes a change in their quality of life pretty significantly, pretty quickly.
I would think climbing the steps right after surgery would be really a tough one. Uh,
It it can be, but once again, you're talking about a patient population that's already kind of adapted to doing those activities of daily living with pain. So they'll still have pain, but it's different than their arthritic pain. So they're already kind of accommodating that to some degree.
Gosh, interesting. It's very interesting. That can compare. That's interesting to what I've heard over the years from a lot of customers that would coming into the store. Oh man, this has been really a tough one, you know. But that was years. That was years ago, you know.
Yes.
So
So that was years ago, and once again, the biggest, I would say, one of the biggest changes in that dynamic has been education and just managing patient expectations and really spending the time, whether that be in your office visits or we offer a class to our total hip and knee patients beforehand, where one of our employees kind of goes over everything. We have a PowerPoint, answers any questions. So because the more that they know beforehand, and the more that they know that they're able to do, the less anxiety they have, and frankly, if you look at the research, the better outcomes that they have as well.
go ahead, Brad.
So how would a knee surgery be different from, or an outpatient knee surgery be different from a hip?
So I would say the percentage is about the same in terms of how many we're doing. Um, Knee replacement and recovery is a little bit more difficult for the patient. Typically, it's a little bit more painful. The mechanics of a knee are very different than the mechanics of a hip. So, you have a ball and socket hip that you replace with a ball and socket, and there's something that we talk about in the research called a forgotten joint score. And most people that have hip replacements end up forgetting that they even had them done, just because it's just such a similar biomechanics, and there's not a whole lot of changes there. Most knee replacements feel better, but they don't necessarily forget that they had it done, just because of the complexity. If you think about it, the knee flexes and extends, it rotates. There's, translational forces, there's angular forces. So regardless of how good we do, it's still different. So it takes a little bit of getting used to. And the recovery is harder because, we do this surgery, we make this incision, and then we tell you to move, right? So you really have to work on your range of motion and your strengthening right away to maximize your outcome. But when you do that, it is more sore than a hip is typically. But the same thing goes at this point from a patient selection standpoint. I mean, we're anybody that is healthy enough and has the help at home, we're trying to do as an outpatient so that, we can get them back on the road to recovery.
How long does a typical hip replacement take surgically?
Well, there's a lot of different things that come into play there. When I'm talking to a patient, I usually tell them 2 hours, but that gives me a lot of leeway, right? So that's, getting into the room, getting the room set up, and then as well as, getting the whole surgery done and then getting out of the room. But I would say that the surgery itself is, anywhere from 45 minutes to an hour and a half.
Gosh, it's just amazing. Robotically, correct?
Well, so I do almost all of my knees robotically. The hips, I do probably 25 to 30% of my hips robotically. And when I do an anterior kind of minimally invasive hip, I don't tend to use the robot. And that's because in that scenario, I'm able to get an x-ray of that patient live. So I don't need the robot to kind of help with that accuracy and that precision, because I know exactly where I'm putting them because I can get an x-ray. And when I do use a robot on a hip, it tends to be for those more complex patients that have, either a significant deformity of the hip itself, or maybe they have a significant history of lumbar surgery, which complicates kind of the hip spine relationship. And in that scenario, I'm doing it a little differently. And I really sometimes want to dial in where I'm putting those implants to allow for the best outcome.
Wow. Okay, doctor, our final breaks here. You're listening to Health Matters with the Medicine Center Pharmacy. Welcome back to Health Matters with the Medicine Center Pharmacy. I am your pharmacist, Paul White. Thanks for joining us. Let's get back to the last segment of the show.
All right, doctor, is there anything else you want to talk about as far as robotic surgery, or should we move on to other subjects?
Well, I think the big takeaway from robotic surgery is not necessarily, robot is a little bit of a stretch of the word, in that it's not taking anything out of our hands or doing anything on its own. It's really just a tool that allows us to really dial in the precision and the accuracy of what we're doing. And I think it makes a huge difference. In a knee replacement, it allows us to do things and that we haven't been able to do reproducibly. And what I mean when I say that is I can change the amount that I'm cutting in a knee replacement by 1/2 degree and 1/2 millimeter to tension the ligaments just right, so that I know I'm putting every knee in exactly where I want to put it. Whereas historically, we've done a lot of that on look and feel, and that has done very, very well. But this really allows us to put it in exactly where we think it needs to be to provide the best outcome. And in that, we're dissecting a little bit less and doing a little bit less soft tissue damage in hopes that the patient will recover a little bit faster.
Okay,
So
cars are driving themselves. When is the robot going to be driving itself?
I don't want to talk about that.
I know. I'm just thinking about these cars.
No, I know.
Running around New York City.
I don't think we're close to that at all yet, but once
Okay.
again, it's just, it allows us to kind of reproducibly do things that we couldn't do without that precision.
Sure.
Does robotic surgery go along with minimally invasive, or could you still do a minimally invasive procedure without the robotic assist?
So certainly, minimally invasive really is just, when you think about it, the definition is just the length of the incision, right? So you can do, so, and like I said, I don't do most of my hips with the robot, and I do them minimally invasive because, it's just, the robot is a tool that
Mm.
allows us to do things differently. So it's not a necessary tool, nor does it change kind of the approach or how we do it. So you can do minimally invasive without the robot and minimally invasive with the robot, depending upon the patient and what you think is best for them.
Wow, that's amazing. So, we're a little short on time here, aren't we, Brad?
Yeah, maybe we should talk about their express clinic.
Yeah, okay.
Yeah. So, we have express clinic locations at both of our Omni location here on Belpar, as well as the Frank location of OrthoUnited. The goal of the express care clinics is specialized orthopedic care for acute and subacute injuries, primarily to keep you out of those long emergency room waiting lines and things like that. So sprains and strains, acute shoulder pain, elbow pain, knee pain, bumps and bruises and all those kind of things we're happy to see. We try to get you in and out as efficiently as we can. And once again, to try to avoid those 6, 8, 10-hour wait times in the emergency room.
I need to comment here because your team took care of my wife almost a year ago next week, and it was a rather impressive experience. We showed up there at like 5:00, and I didn't know it at the time, but she had her lower left leg broken in 3 places, and they had her x-rayed, and it wasn't a cast, it was a splint, but they had her x-rayed, splinted, and seen and taken care of literally in an hour and 20 minutes.
Yeah.
And it was a very difficult time, but your team was awesome. And I can't speak enough to the efficiency and keeping the patient at the center of the care. So it was
Yeah.
really nice.
And I second that. The several times that I was at the new facility, just terrific. Yeah, the organization was just fabulous. Push you right through there, man. Okay.
No, and I mean, once again, that's our goal is to put
Yeah.
patients first. And it was one of the reasons that we combined, was to allow us to keep that efficiency and that specialization and that, patient first attitude and goal all the way through.
Mhm.
So since we're getting tight on time, how about you've commented a little bit on your locations. Can you share with the listeners again where your offices are located, how to find you online, and maybe when to make sure they seek care if they're not sure whether or not they need to seek care?
Sure. So our new website is OrthoUnited Ohio. And it is up and running. All the information in terms of phone numbers and things like that is on that website. In terms of location, from a OrthoUnited Omni campus side, we have offices on Belpar, which is where our express care clinic is located. We also have an office in Alliance and an office in Dover. And then our surgery center is Oasis, which is on the corner of Portage and Whipple. From an OrthoUnited Spectrum campus side, they have their main office on Frank, which is where their express care clinic is located, and their OS3, or their surgery center, is located there as well. And then they also have a physical therapy office located in New Philadelphia as well. And like I said, the goal of all of this is really to continue to provide top of the line, excellent, efficient, specialized care to the Canton community. And we all live here. Some of us were born and raised here, some of us weren't, but I'm happy to be an adopted Canton resident, and really just to continue to do the best that we can to keep providing high level care. I think the takeaway in terms of when to seek orthopedic care is really just, anything that stops you from doing what you want to be doing on a day-to-day basis. In an acute setting, if you fall down and sprain and do something and you're not able to get up or put weight or move it, you need to seek care at the express clinic for urgent evaluation to make sure nothing is broken or dislocated or out of place. In a chronic setting, I would say once it has failed those, kind of the RICE, which is rest, ice, compression, elevation. So if those things aren't helping you and your quality of life is affected every day, give us a call and any one of us is going to be happy to take a peek at you.
Do you enjoy any other surgery? Any other than any other?
So
I
it's
mean,
it's funny. I because we're all so specialized. I love hip and knee replacement, and that's why I specialized in it. And I would tell you that I love hip replacements and knee replacements for different reasons. Hip replacements are so much fun to do because once again, they truly change the patient's quality of life almost instantly. The patients that have debilitating hip pain and they're not getting, you see them at that first post-op visit and they love it already. I really enjoy robotic knee replacements because once again, the technology allows us to really do things that we haven't been able to do before and to really just dial things in and make these very minute changes that we were never able to do. It's a lot of fun, I think.
wow, it's interesting. Okay, you say minimally invasive on a hip. How large is the incision or?
So the incision is anywhere from, kind of, I would say 4 to 6 inches on an anterior hip, which is, right about there. The thing about that is bigger patients get bigger incisions because we still have to see. The biggest thing for minimally invasive in a hip tends to be the approach, which in an anterior approach, like I said, is kind of, in between muscle planes rather than through them, which makes that the biggest difference in those first 2 to 3 weeks postoperatively in regards to pain.
Wow, that's interesting. I'd say we're out of time. I'm Brad.
Yep, we are.
I wish we had more time. It's very interesting talking with you. And both of us had, experience with your facilities. It makes it even more interesting to kind of
very much. Well, I appreciate you giving me the time too. It's been a lot of fun.
We'd love to have you back. Thank you very much, Dr. Matthew Stonestreet from OrthoUnited. If you suspect you have a medical issue, please contact your healthcare provider. Thanks to Altman Health Systems and our listeners for joining us on Health Matters with the Medicine Center Pharmacy. Have a healthy weekend. We'll see you right here again next Friday on News Talk 1480 WHBC.